Why don't we get started? Good morning, everyone. Thanks for coming to Department of Medicine Grand Rounds. Happy to see all of you here. And I will turn it over to Dr. Bierkens to introduce our speaker.
Hey, good morning, everyone, and welcome to Grand Rounds. We are lucky today to have Dr. George Bacris speaking to us from the University of Chicago. Dr. Bacris is a nephrologist and certified hypertension specialist who trained at Mayo as well as the University of Chicago. He is a professor of medicine and is the director of the American Heart Association Comprehensive Hypertension Center at the University of Chicago. He has published over 900 peer-reviewed articles and book chapters in the area of diabetic kidney disease, hypertension, and nephropathy progression. He is the editor and co-editor of 23 books in the areas of diabetic kidney disease progression and hypertension. Additionally, he is the co-editor of the 3rd and 4th edition of Hypertension, a companion to Braunwald's The Heart. He has served on the FDA Cardiorenal Advisory Board and is consultant to CMS, and has served on many national guideline committees, including the Joint National Committee JNC7 Writing Group, as well as the ADA Clinical Practice Guidelines Committee. We are extremely lucky to have him here today and hear about his recent work. Please join us in welcoming him. Thank you.
Thank you very much. Very much appreciated. And I mean, the title looks very, forward-looking and Star Wars-like, but I really want to hopefully change your thinking about this, because we have a lot of information, and I've realized lecturing that the application of these new methodologies is really where people are stumbling and there's questions. So I'm going to hopefully try to answer all this. Let me proceed here. There's my conflict of interest statement that I was asked to put in. So let's start off with the basics. And the basics are that kidney disease, defined as a GFR of less than 60 and definitely less than 45, should be thought of as a cardiovascular risk factor. And I'm going to build on that a little bit. But the evidence is overwhelming now. I said that 15 years ago, but now the data is clear that it is a cardiovascular risk factor. And the other concept, especially for cardiologists and general internists, is that microalbuminuria is a marker of inflammation. And in fact, there are studies showing that microalbuminuria is a better predictor of inflammation than CRP. So those are concepts that may be new to you, but you need to embrace those, because that is the way it is. And we'll get into this. But take a look at this. This is an epidemiologic study from the great Kaiser in California. And Alan Go, who basically pioneered this, made some very startling findings, at least at the time. This is 2004, that if you have stage 3 BCKD, and for the unanointed, that's a GFR of less than 45, you have a almost 5-fold greater risk of all-cause mortality compared to having even stage 3A. And your cardiovascular event rate skyrockets to 11-fold higher than stage 3A. So both are kidney disease. One is just a little more advanced. And of course, if you have further worsening of kidney disease, you can see it's really dramatic. So that's important concept number one. Concept number two, if you have kidney disease, and this is an analysis done at the Mayo, but if you look to the left, people with kidney disease, your heart failure rate, CHF represented here, is 3-fold higher than if you don't have kidney disease. So very important points to understand that kidney disease tracks with heart failure, as well as increases the mortality rate from cardiovascular events. So for the non-nephrologist, I think we all have to be on the same page. So this is the KDIGO heat map that was pioneered by Andy Levy at Tufts, and I was privileged to be on the original committee back in 2002 when we put this together. And this is really kind of plagiarized from the cancer guidelines. So you have stage 0, stage 1, stage 2, and it's reflective in the GFR stages here and the levels of GFR. And obviously, the lower the GFR, the higher the risk, not only for progression to dialysis, but this is reflective of cardiovascular events as well. The other important point here is you cannot make a diagnosis of kidney disease just with GFR. You need albuminuria. That's why it's across the top. So you need those two variables. And so you'll hear nephrologists talk about stage 3A, A2, or 3B, A2, or A3, because they're incorporating the albuminuria. You'll notice the different colors. And obviously red is bad, orange is bad, green is okay. So this needs to be communicated, because each patient fits on a different little square. This needs to be communicated to the patient. You have no concept of how many people have kidney disease and don't have a clue. And so they end up on my doorstep as a referral, and I have to tell them that they're not ready for dialysis, but they're going to be ready for dialysis within the next 5 years. Not good. You can change the trajectory of kidney disease decline, but you got to know how to do it, and you got to take the time to do it. It's not a piece of cake. So this is what's important. You'll notice there's enhancement of an area there. That is what we knew about slowing kidney disease in 2001. And basically put ACEs and ARBs in the drinking water, and we're good. We've come a long way since then. I just want to make another final point about albuminuria. That this is a excellent report looking at a distribution of a 2-year albumin-creatinine ratio in over 19,000 patients. And you'll notice that it correlates with the lower you go, the lower your ESRD risk is, but also the lower your mortality risk. So they do track together. We're going the wrong direction. These are data looking at dialysis rates in the world. If you look at the left, you can see by 2030, we will have almost doubled, well, we will have doubled the dialysis prevalence than it was in 2010. And while Asia is leading the pack, we're right behind. So we need to improve this. This is not the ultimate endpoint. And I think a lot of people have said, well, it's a given. It's not a given. You can change this, at least in diabetes, for sure you can change this. So this is the two seminal trials in 2001, RANAL and IDNT, and look at the residual risk. Now you'll wonder, why is this guy showing us the dosage of the drugs? Because ARBs and ACE inhibitors are profoundly underdosed. If you think that you have to open the bottle, lick an ACE or an ARB, put it back in the bottle, and you're protected, you're an idiot. No way. You need to give the doses given in the trials, or it won't work. It's as simple as that. So let's talk about this. Down titration of RASS. Who's doing who a favor? So if you look at RANAL and IDNT, and you look at the people that got reduced doses in the trial, so they still were in the trial, but they got reduced doses. In RANAL, people got reduced to 50 milligrams of losartan. There's no proven renoprotective effect. With irbesartan, when you reduced it to 150, no proven benefit. If we then look at bigger databases, and you look at whatever you want to look at, heart failure, stages 3 and 4 CKD, diabetes, if you look at the people on submaximal doses, that's the orange bars, and compare it to the gray bars where the drug was discontinued, there's no difference. So giving lower doses of the drug, you might as well save the money and not give it. You're either giving it or you're not giving it. It's as simple as that. And the beauty is, in 2009, the FDA put out an edict, if you will, that there are no dose-dependent side effects of ARBs. Therefore, you should start at the maximal dose. And that's true. So all of these alleged fears that people have, they're not there. There's no coughing. Angioedema rates are dramatically lower than they are with ACE inhibitors, and they're rare anyway. So you need to think about this. Now, my other pet peeve is the creatinine goes up and, oh my God, we have to stop the ACE or the ARB or whatever else we're doing. Wrong. And we have good evidence for that now. But here's some evidence. These are people with stage 4 CKD. GFR is less than 30. From the Geisinger, 3,900 people. And what you see here, it's retrospective, but propensity matched. And if you look at that on the right, those are the propensity match scores. You can see that those continued on ACEs or ARB therapy did better with regard to reductions in all-cause mortality. So that's a big deal. But the other big deal is fewer people went on to dialysis when continued on an ACE or an ARB. So important information. Now you're going to say, wait a minute, what about hyperkalemia? What about all? Yeah, guess what? We can manage that. You got binders. There's all kinds of things you can do, and we do them all the time. That isn't being taught in the residency. It's a big problem because that's where we learn our skills. But you can manage this very easily. Then we have the Stop ACE study, which was going to definitively disprove what Matt Weir and I published in 2000, that a rise in creatinine is bad for you, not that it's good for you. Well, these are the people, this is the distribution of the studies, of the people in the studies: glomerulonephritis, diabetic nephropathy, 21% of the people in there. Blood pressures were not perfect, but they weren't that bad. And if you look at the distribution of people with GFRs, you can see that the majority were above 15, stage 5, or you still had about 28%, 29% that were less than 15. What did you find? No difference. There's no difference. And in fact, the continuation group looks like it did a little better, just like the Geisinger group did dramatically better, but here did a little better than the discontinuation group. And if you look at time to dialysis, you can see here that it was better if you continued it. It was not statistically significant, but clearly the trend was lower. So we've got RASS blockade as a pillar of therapy. Where did this concept come from? This is new to nephrologists because we only had the RASS blockers. The cardiologists, the heart failure cardiologists, this is old news because they've now got 4, potentially 5 drugs they can use in heart failure, and they use them all. They don't sit there and go, well, I'm going to pick this one or this one. They use them all because they've all been shown independently in clinical trials to reduce mortality and hospitalizations. So how did we get to this point? Well, we weren't sitting around. There were a number of studies that were done to try to slow kidney disease progression with a variety of different agents. All failed. So what emerged were the SGLT2 inhibitors that no one had a clue would be that protective to the kidney, and the nonsteroidal MRAs, which were purposely developed to be better spironolactones with fewer side effects. And that's another story in and of itself, but we'll get to that. So when you look at the SGLT2s, there are only 3 trials. I didn't put the EMPA-KIDNEY in here, which was just published, but there were 3 trials looking at progression of kidney disease in people with kidney disease, large amounts of albuminuria, low GFRs, and all of them show benefit, all of them. And it's irrespective of atherosclerotic cardiovascular disease. This is a nice meta-analysis that was done. There's a more recent one that was just published, including EMPA-KIDNEY. Basically, the message is the same. Kidney protection is there whether you have atherosclerotic kidney disease or not, period. And this is data from EMPA-KIDNEY itself, which shows something interesting. And if you look here at the bottom, this looks at albumin or creatinine ratios. So clearly every study shows if you've got more than 300 milligrams of albuminuria, you've got big time protection from the ACEs and the ARBs, from the SGLT2s, it's there. If you have microalbuminuria, there's definitely a trend towards benefit, but the standard error bars are big because the numbers are small. And if you have normal albuminuria, you get no protection at all. And that's been shown in some other studies too. So the notion of putting ACE inhibitors in the drinking water, forget about albuminuria. Who cares? You've got kidney disease, put it in there. A little questionable if you're normal albuminuric. Microalbuminuria, there's other studies that do show a benefit. So I think we need to kind of back off a little bit because this is one study. But that's another reason to measure albuminuria. So I'm showing you this because I was asked by the editor of the American Journal of Kidney Diseases in 2019, when he noticed that SGLT2 inhibitors were not being used by nephrologists, that I should write something as a perspective to get people off their rear ends and start writing this because it's renoprotective. So I concluded that SGLT2 inhibitors are cardiorenal risk-reducing drugs that happen to lower glucose, but it doesn't matter what your glucose lowering is. It's irrelevant. You're getting protection. As an aside, just so you can laugh from the boys across town, I was asked about a year and a half ago to give grand rounds at Columbia. And it was a Columbia Cornell thing. And one of the things they wanted me to do is talk about the mechanism of SGLT2s. And I asked them, I said, are you sure it's the mechanism? And they said, yeah. So I show up, first slide shows 11 different mechanisms. And I said, which one do you want to start with? And they're like, oh. So I think it's important to understand that we don't fully understand how these drugs work. It's not just by lowering glucose. But I think it's important for you to know that the new recommendation goes down to a GFR of 20. I guarantee you, you're getting no glucose effect at 20. I also guarantee you, you're not getting an osmotic diuresis. That's a separate issue, and I don't want to go there. I just want to make the point that these are important drugs that need to be used. And so we have these studies, and basically, you just kind of put them in the drinking water of sorts. The ADA guidelines, which I was privileged enough to be part of, the most recent ones, mandate if you have kidney disease and diabetes that you must be on an SGLT2, period. You want to use metformin, that's fine, but you need to be on an SGLT2. If you have heart failure without kidney disease and diabetes, you must be on an SGLT2. So the data has hit the guidelines. It's pretty overwhelming, and it's important. Now, it's not just the ADA. There was a recent Kumbaya moment that I was privileged enough to be senior author on of the ADA and the KDIGO diabetes group. And you can see here, SGLT2s are right up there. If you're in green, you need to be part of the cocktail to slow kidney disease progression. But 100% of what you see on this slide is what it takes to really make a dent in slowing kidney disease. So it's not easy. So we have a second pillar, the SGLT2 inhibitors. Now, throw the SGLT2 inhibitors in with RASS blockade, we still have a lot of residual risk. And what are we going to do about that? And what is that being accounted for? Well, I think we all know diabetes is an inflammatory state. So we really need to reduce inflammation. We've done a good job with blood pressure. We've got a reasonable job with metabolic control, but there's other stuff going on. So mineralocorticoid receptor activation has been underappreciated in a number of conditions. The cardiologists have realized this back in the 70s with early studies by Carl Weber in heart failure, showing the contribution of aldosterone and heart failure decline. And so now in diabetes, there's excellent evidence has been accumulated since the late 80s that mineralocorticoid receptor activation is a big deal. Not only a big deal for the heart, but a big deal for the kidney. This is one of the pillars of the cardiologists in treating heart failure. And it's now, as I'll show you, one of the pillars for nephrologists. So very important point. And I'm not going to get into this because this just gives you a flavor for the pathophys that's involved, but it's important to understand that this should not be ignored. Now, a lot of us have used spironolactone and Finerenone, and we know that these drugs have a lot of side effects, and a lot of people can't tolerate them. There are benefits, but they're limited. So there was a dedicated effort that took 10 years to do by some chemists at Bayer to develop a mineralocorticoid receptor activation compound that didn't have all the baggage that spironolactone and Finerenone have. So they developed Finerenone. And you can see that they weren't alone. There were other non-steroidal MRAs being developed, and these are not your mother's spironolactone. In fact, the FDA has labeled them as a new class of drugs. So keep that in mind. And I'm going to show you beyond the chemistry, which is clearly different, that you can see some of the other issues that are involved. You can see here differences in structural properties. And that's important because while they block the receptor, they activate different genes than spironolactone or Finerenone do. These are nicely reviewed in a couple of papers that were published last year, one of which I was privileged to be an author on, where we get into this, and it gives you a hint as to why the side effect profile may be different as well. But it's important to know that the binding is different. The potency of Finerenone is similar to spironolactone, so there's no difference there. The selectivity is far greater than either spironolactone or Finerenone. There's no CNS penetration, no sexual side effects, and a short half-life, 2 to 3 hours, even though you get 24-hour effect. For those of you that are good with ARBs, it's the candesartan of the agents, because candesartan has a half-life of 2 hours, yet controls blood pressure for 24. So, important point, no metabolites, and the effect on blood pressure is modest, but there is an effect. So, what is the Finerenone program? And I call it a program because when we designed this, it was meant to have one protocol, similar centers recruiting patients around the world, so that when we were finished, we would put all the data together, and so we can do an individual patient-based analysis, the fidelity, DKD. But the inclusion criteria were different, so the primary endpoints were different. So what am I talking about? Well, when you look at the protocol's on top, you can see here, first of all, we mandated everybody needs to be on an ACE or an ARB at maximal tolerated dose, number one. And then if their GFR was less than 60, they got randomized to 10 milligrams of Finerenone. If it was 60 or higher, they got 20 milligrams. The people that got 10 milligrams, if their potassium was good within a month, they got titrated up to 20 milligrams. In both trials combined, 72% of the people were on 20 milligrams. And if they didn't get that, they got placebo. And you can see the numbers are pretty large, over 13,000 people combined in both trials. Fidelio is a primary renal endpoint study with a greater than or equal to 40% change in GFR, ESRD, or kidney death. And the pre-specified co-primary endpoint was a MACE endpoint with heart failure hospitalization added. The Figaro trial was a healthier group of people. The mean GFR in Fidelio was 44. The mean GFR in Figaro was in the low 60s. But here, cardiovascular events were number one, and the kidney endpoint was number two. Same events. Then when we put all the data together, we wanted to get even more strict with endpoints. So we redid the analyses, looked at doubling of serum creatinine, ESRD, or death for the kidney endpoint, and the cardiovascular endpoint was the same. You can see this was distributed around the world. And when you look at the kidney endpoint, you get a 23% risk reduction. Now remember, there's no SGLT2s here. In fact, in both trials combined, is around 8%. We're getting SGLT2s, 8% of 13,000 people. But here you can see 23% risk reduction for doubling of creatinine, ESRD, or death. And what's really important here is when you look at the individual components of the renal endpoint, they were all positive. And in fact, you get a 20% reduction in dialysis alone. So very important observation to keep in mind. For the cardiologists, 14% risk reduction in a MACE endpoint, and that was consistent going out for 4 years. When you here look at the individual endpoints, this was driven almost exclusively by heart failure hospitalization, similar to what you see with the SGLT2s. When you look at cardiovascular death, didn't quite make significance, but certainly was just missing it. So when you look at an all-cause mortality analysis, and you compare the primary analysis to the on-treatment analysis of Fidelity, you can see on the on-treatment analysis, all-cause mortality was significantly reduced, as was cardiovascular mortality. This is why in the FDA label, it has a label for reduction in cardiovascular mortality. So again, important points. Now, what's the conclusion of these studies? First of all, if you give Finerenone together with maximally tolerated doses of ACEs or ARBs, you get a 22% reduction in hospitalization for heart failure, and you get a 20% reduction in dialysis. Not bad without an SGLT2. Now, I haven't mentioned hyperkalemia, and everybody's like, oh yeah, right. What about hyperkalemia? Okay, here you go. 110 people out of 6,500 were discontinued in the study because of hyperkalemia. In the placebo group, it was 38 people out of 6,500. So yes, there's hyperkalemia. Is it so bad that you can't use the drug? No. Is it as bad as spironolactone? Well, I can't answer that from these studies, but I can tell you from other studies, you get about 1/10 the hyperkalemia that you do with Spiro. Same kind of GFR range. So important point. Now there's some benefits in the subgroups that we looked at of the people that are taking both Finerenone and an SGLT2. One is your risk for hyperkalemia dramatically reduced. And this is in the diabetes study, the diabetes cohort, where bottom line, we looked at the subgroups here. Interesting, you did better if you were on an SGLT2 than you did if you were on a diuretic for reducing the risk of hyperkalemia with Finerenone. Observational data, but just making the point. Another important analysis that was just published, and this looks at people on and off SGLT2s. I told you we had about 8% of the people on SGLT2s. Again, observational data. But if you look at the on-treatment period, which is the bottom half of this, interestingly, hospitalization for heart failure was dramatically lower if you were taking an SGLT2 compared to not taking it. Now you'll notice that the numerator is very small. And I said, these are observational data, but I want to make the point that you can get additive benefit, and there's animal studies clearly showing additive benefit. But I think it's important for you to understand these are complementary mechanisms here. They're not the same mechanism, and yet you're getting the same outcomes and some evidence of additivity. Now, for the nephrologist in the group, I'll show you what we found when we added albuminuria to this. And this looks at albuminuria over time. The blue is the Finerenone group, the orange is the placebo group, and the solid line are the subgroup of people on SGLT2s. And you can see that you got greater albuminuria reduction compared to not being on an SGLT2. So let's talk a little bit about blood pressure. Not a lot of blood pressure seen in the Fidelio trial or the Figaro trial. But we went back and looked at the data in quartiles. Did it matter what level of blood pressure you had? And was there any effect on 24-hour ABPM? Now, this was not done from these studies. This was done from the phase 2 study that we did that led to the development of the Fidelio. And this is the ARTS-DN. The ARTS-DN, by the way, for your interest, I didn't put the reference here, it was in JAMA 2015. But if you look at the dosages here, if you look at the 10 milligram dose and the 20 milligram dose, which is what we used in the study, and you look at the blood pressure effect, there's not a lot of drama here in blood pressure. But if you look at nighttime blood pressure, even here at 20 milligrams, when your blood pressures were reasonably well controlled, there seems to be a greater benefit of lowering at night, which is not seen at the lower doses. So what does that mean? I don't know. It's an observation, and it's something to be thinking of, but the drug does have blood pressure lowering effects. Now, if we then go and look at the Fidelio study with over 5,000 people in it, and we split it up into quartiles of blood pressure, as you can see above here, you can see that in the quartile that's greater than 148 at baseline, in fact, 156 was the office mean, and you can see the distribution of patients here as well, with GFR of 44. When you look at placebo-subtracted, this is a busy slide, but when you look at placebo-subtracted blood pressures, look at the powder blue. The powder blue is the group that is on Finerenone at the highest blood pressure quartile. And you can see here, placebo-subtracted, you're getting about a 5 millimeter reduction in blood pressure. And so, you know, is it really dramatic? No, not really. And if you tried to apply for blood pressure lowering at the FDA, you wouldn't get it based on this data. But it does have an effect on blood pressure. So just keep that in mind. So where does that bring us in terms of the heat map? You can see now we've covered a lot more of the heat map with the SGLT2s and Finerenone. And so clearly we have a lot more people that can benefit in terms of slowing progression of kidney disease. And you'll notice these are people at the higher GFRs. It's not people at the lower GFRs. We already covered that. So we have a third pillar, Finerenone. But you'll notice there's a fourth pillar that's vacant. What are we going to do with that pillar? Well, let's go back and take a look at the history of where we came from and where we are. So in the 1970s, 1980, early 80s, we had no specific therapy for CKD progression. And at that time, and mostly type 1 diabetes, but also type 2 diabetes, you were losing about 10 mLs per minute per year, which means if you came in with normal kidneys, in 10 to 12 years, you'd be on dialysis. And so we then had the ACE inhibitors and some other smaller studies. We then had the ARBs, and now we have Finerenone and the SGLT2s. We're still not normal. The dotted line above is the normal line. So we're close. We got a lot closer, but we're still not there. So what else can we do in terms of trying to slow the disease progression? What other pillar can we fill here? Well, enter the glucagon-like peptide receptor agonists, the GLP-1 RAs. We already know, the cardiologists are very confident that these drugs reduce cardiovascular outcomes. They do nothing for heart failure, interestingly, but atherosclerotic events, they're very, very effective in reducing events. A complement to the SGLT2s and to Finerenone. But when you look at the subgroups, you go back and look at data in subgroups from the two big trials, you see there's a trend there. When you look at endpoints like microalbuminuria reduction, ESRD, doubling of creatinine, there's clearly something there that needs to be looked at. But these are, post hoc analyses. And if you look at this analysis in LEADER, In the subgroup of people with stage 3, clearly there was a reduction in the number of events, and the events are a doubling of creatinine, ESRD, or death. So the ongoing trial that is going to answer this question is the FLOW trial, over 3,500 people, fully recruited, I might add. And we set it up to demonstrate that semaglutide delays the progression of renal impairment and lowers the risk of renal and CV mortality in type 2 diabetes. Now, there's a sister trial to this called SOUL, which is a cardiovascular trial in a similar group of people. So, important to understand that the GLP-1 RAs may be filling the fourth pillar. We won't know the results of this trial until next year sometime, but a lot of us are confident that it's going to be positive. I might tell you there's double the number of people on SGLT2s as compared to the Finerenone trial that got into the study, and we didn't limit that. So it's going to be interesting to see what the results are. So stay tuned, because we may have a fourth pillar that's filled, and that's the GLP-1 RAs. And then we will be similar to the heart failure cardiologists, we, the nephrologists, and I dare say the internists, because we will then have 4 drugs that independently have shown benefit on slowing kidney progression of kidney disease. And by combining them, as the cardiologists have done, we definitely are going to get better results. Now, somebody asked me, I'm going to anticipate the question, well, how can you say that? There's no outcome trial. And oh my gosh. Well, let me tell you something. You want to do an outcome trial and test this? That's not a problem. My guess for the N would be 150,000. Not sure you're going to be able to do that. So get a grip and use a little common sense in terms of looking at this data and how we can use it together. So I'm going to finish with that and be happy to answer any questions or comments that you have. Thank you very much.
Great, thank you. So questions, comments? I don't think there's anything in there yet. One just came through. Let's see, why the antihypertensive effect of Finerenone is not like aldactone.
One of the things that you need to appreciate about aldactone is that it is a prodrug. It gets metabolized to canrenone, and canrenone has the blood pressure lowering effect, and there are other metabolites that are generated that have effects on androgens, that have effects on other hormones. And interestingly, a lot of people think that 25 milligrams of spironolactone is a diuretic. I have bad news for you. It is not. You need 50 milligrams to actually get a diuretic effect. The House staff didn't believe me, so I had to go back and resurrect the paper from, I think it was like 1978, that actually showed this very nicely. So I think it's important to keep in mind that these effects that we're seeing of spironolactone on blood pressure are not because it's a diuretic.
Gotcha. There's a question, asking how can patients afford to pay for all these medications?
Of course, and it's an excellent question. What I'm understanding is, first of all, you should know that dapagliflozin is going generic next year. So there will be an immediate cut there. But depending on the policy that you have, the insurance policy that you have, a lot of companies will certainly pay for some of this. I mean, you're not going to pay $300 for the drug. You can get it for $40. And there are programs that companies have for specific needs where you can get them. And the same is true for Finerenone. Now, Finerenone's been approved by Humana and one other carrier, and it's available at the VA. So you can get it there for reasonable prices. But again, this is a big problem, and I understand that. And a lot of friends of mine who are very knowledgeable and they know all this data say, well, what if I just use Spiro? The truth is, there's no head-to-head against Spiro. Would Spiro work? Well, I think we have good data. In proteinuric kidney disease, Spiro does work. Does it change outcomes? We don't have outcome data. Why? Because of hyperkalemia. So if you're willing to give one of the potassium binders, patiromer, Localma, I mean, that's fine. And some people can do that. Oh, guess what? Those are expensive too. So, and the programs that get those are not as good as the other programs. So it's unfortunate that where we are now is we have a lot of tools that we can use to slow progression of CKD. And the price is prohibiting physicians from using it. And to do prior RASS and all that, nobody's got time for that. So I think the government needs to hear this, not you guys.
Thank you. Other questions, comments? There we go. Thank you for a great review. Many of our old patients are unable to tolerate higher doses of ACE or ARB. However, they are at risk of progression of CKD. How can we apply your data there?
So that's an excellent question. The major reason, first of all, I don't use ACE inhibitors in older people, period. And I have a lot of Black patients, so I don't use ACE inhibitors in them either. So ARBs are my, sartan du jour is where I go. And I didn't give you a part of this lecture on that, but there are big differences within the sartans. So if you really want blood pressure reduction, you need to use either olmesartan or azilsartan. Now, azilsartan is not generic. And so you could get some pricing challenges there as well. Telmisartan isn't bad. Losartan and valsartan are not good blood pressure lowering drugs. And the reason is the binding at the ARB receptor, the A2 receptor is different. And so if you're using losartan or valsartan, you're getting about 55% binding. If you're using telmisartan or olmesartan, you're getting about 80% binding. So it's very different. This has nothing to do with half-life. So it's important to understand that difference. Second, older people don't drink fluid. If you don't drink fluid, even losartan can be powerful in a maximal RASS blocking, RASS activated state. If you block it, you become hypotensive. So I tell all the older patients they must be drinking at least 1.5 to 2 liters of fluid a day. And it doesn't have to be water, it just has to be liquid. And then they won't get the hypotension. So that's one way you can get them to tolerate.
Gotcha. Another question just came through. Are there other anti-inflammatories that might be helpful in reducing CKD progression?
Yeah, there may be. There's a couple of them being tested, and you're complaining about the price of Finerenone and SGLT2s. These are like $4,000. So I don't think that those are going to be viable for use. They're being looked at more in the cardiovascular literature. There's no question, Paul Richter's made his career on this. There's no question inflammation is a major part of this thing. And how do you really quell it in an important way? That's easy to do. We have the drugs, but the drugs are expensive, or they may require infusion. So that's a problem. That's a problem.
Another question is, what is the mechanism of reducing fibrosis with Crendia?
So the mechanism of reducing fibrosis with Crendia, well, here's the thing. The blockade of, and this would be appropriate for all MRAs, the mechanisms that are stimulated by mineralocorticoid receptor activation, and I showed you the one slide with all the different markers, TNF, alpha, et cetera. If you're blocking those, you're reducing the effect on fibrosis. I think conceptually, I'm going to tell you what I tell patients. And that is, fibrosis doesn't just happen. there's inflammation that's prolonged, and then ultimately fibrosis develops. And so the bottom line is, if you can stop or reduce the inflammation, the risk of fibrosis drops dramatically. If you have fibrosis, its reversal is almost impossible. It's not impossible, but it's very difficult, because it's like having rust develop on a car. Unless you change the metal, there's no way you're going to reduce the rust. So I think that's a concept that needs to be put forth.
Oh, Joe, we have a question. Great talk, George. This is from Joe Vasiliati. Can you comment on the approach to DKD with HFrEF, since that population was excluded from the Finerenone trials based on prior trials?
I missed part of the middle part of there. The population of specifically with what?
Comment on the approach to DKD, Joe, with HFrEF, since that population was excluded.
Yes. So the reason HFrEF was excluded is because there's specific guidelines, at least in the US, that spironolactone must be used if you have HFrEF. And we did not want to get into that kind of thing, because then our N would be much higher. So we included HFpEF, we did not include HFrEF, and there's a trial going on right now that is fully recruited in HFpEF. So we are not going to have data on HFrEF, because it would have to be a trial designed to be, I'm not sure what they want to do. They'd want a superiority trial. And I think to do a superiority trial against Spiro, you would need a tremendous number of people, and they just don't want to make the investment. So I don't think we'll ever have data on that. I will tell you that I do know of cases where HFrEF or Spiro was not tolerated, and they did give Finerenone, and those people did well, but that's anecdotal. There is, I will say, since Joe didn't ask this, but I think a lot of nephrologists want to know, and endos for sure. We've been screaming at the company to do a type 1 study, and they kept saying no. Finally, they did go to the FDA, and the FDA said, based on the data that we already have, if they just do a study in type 1 and show reduction of albuminuria, they probably will get an extension for type 1 diabetes. So that's actually happening as we speak.
I was waiting for Joe to put a question in there. Great. Any other here's a question from one of our geriatricians. Any caveats for the population 85 and older in terms of meds you discussed?
Well, I have to tell you, I would say yes. The number of people in the study that were over 85, I don't think there was anybody over 85. I think the oldest patient in the study was 82. The caveat is that drug metabolism is a little slower in those people. And a lot of this stuff that I'm talking about fits an age group of 30 to 75. And so when you get to that group, I think judgment of common sense is better. And so it's tough to get an 85-year-old to be drinking and doing a lot of stuff. There are people that do that. But I think you have to take each case on its own and do the best you can. And as long as you've got blood pressure reasonably controlled and what have you, then I think that's the best you can do. So no, I can't give you any guidance there. I'm sorry.
No, I just clarified a question with Dr. Robari. When will you use diuretics, if ever?
Okay, very good question. I'm not against diuretics. Diuretics are important, but diuretics for me are third line. So if I approach a patient initially, I'm going to start to make sure their blood pressure is controlled, obviously. And if I need blood pressure control, and they're on combinations of an ARB and a CCB, then I definitely will use it, but I will use chlorthalidone or indapamide. I'm not going to use hydrochlorothiazide. Then for diabetes, the SGLT2 will be on board. SGLT2s, you'll get a 3 millimeter reduction in blood pressure across the board. GFR is 20, GFR is 90. That's what you're going to get. Unless your glucose is way out of control and your GFR is high, then you're going to get a lot more blood pressure reduction. Finerenone is not going to give you a big blood pressure reduction, and that's another reason why you can use it and not be fearful that you're going to get a large blood pressure reduction. But again, diuretics will magnify the ARB effect. They will magnify the SGLT2 effect. They will magnify the Finerenone effect on blood pressure. So they should not be excluded. They should be thought of and are very useful, especially in advanced CKD. So, and as you know from the CLIC trial, that chlorthalidone is highly effective down to GFRs of 20. So you don't need loop diuretics. And this notion of PRN Lasix is ridiculous. You're either going to give it or not. And remember, Lasix lasts 6 hours.
Another question, do you recommend to use any SGLT2s with an GFR down to around 20 or just some other certain ones?
No. They're all, these are people who want to do meta-analysis. Well, you only tested it to here. Listen, bottom line, and we even put this into the joint ADA KDIGO thing. You can use them down to a GFR of 20. Now, why can't you use them below that? Well, the FDA said you probably shouldn't because we don't have data. What about dialysis? Well, we shouldn't. We don't have data. Transplant, we don't have data. All true. But this data is being garnered as we speak. So I don't see a reason not to use them from a cardiovascular standpoint. I'm not sure they're going to have any renal benefit if your GFR is 15. I find it hard to imagine. You know, when I tell patients that your GFR is 15, 90% of the house is burned down. And now you're calling the fire department. I'm not sure I can help you. So I think that's the issue to think about. So would I use them in people with GFR 20? I do. And remember, if you're on them and your GFR drops below 20, you continue them. That's the FDA edict.
Great. Any last questions? Well, Dr. Backwards, I want to thank you for coming today to give us Grand Rounds and a very up-to-date review of this topic. Really appreciate it. Obviously stimulated a lot of great discussion for us. So thank you very much for coming today. And thank you everyone for joining and staying till the end. Have a nice day, everybody.
Thank you.